So how many postgraduates are there in your department?
So now there are, so we have DCH as well. So we have 2 DCH and 5 MD students.
Okay, so that's good. And how many faculty?
Faculty, sir, recently, okay, faculty will be like 3 professors, 4 associate professors, and 4 assistant professors. So,
okay, so yeah,
around 12, 11, 12 years, something like that.
Okay. And
SRs,
how
SRs
old
are
is
there.
so this college has been there for quite some time.
Oh yes, sir. It's a very old and very, I mean, renowned.
Yeah,
It is called Shishu Mongol because people used to know it as a children's hospital more
Okay.
than the other departments. Although it caters to all sorts of patients, but it is known as Shishu Mongol, like that. So like for children.
Okay. Yeah, sure. So we'll we'll make it live now. It's already 8.
Yes, sir.
Just hold on,
Okay.
I'll make my presentation. Is there? Good evening, everybody, and warm welcome to our MedEClasses lecture series. And we, as we've discussed earlier, is basically this is every monthly lecture series which we organize with regards to the postgraduate learning program. And this series will be talking more about obesity, which is going to be a very, very important topic that we are seeing importantly in terms of childhood obesity, which is increasing, and there are various issues with regards to that. I'm really honored to have Dr. Somana, who is with us, who is part of our team, and she has been very actively involved in promoting pediatric endocrinology in West Bengal. Dr. Somana is faculty at the renowned Vivekananda Institute of Medical Sciences, Kolkata. Dr. Somana, welcome, and thanks for sparing your time on this weekend. She will be sharing her expertise about the overall topic. I've also got Dr. Sayan Banerjee, who is a fellow in our Department of Regency Center for Diabetes, Endocrinology and Research. And the way these programs are structured is that we will be discussing initially a bit about theoretical aspects, and then we'll go forward with regards to the question and answer session. So before we start off, Dr. Somana, we like to have your views about how important obesity is as a topic or overall in terms of both clinical relevance for both postgraduates as well as for the pediatric trainees.
I mean, it is one of the most common cases that we find in our OPDs, and it has gone up tremendously, especially after the post-lockdown and COVID pandemic. As we know, obesity has been increasing, and it is a global pandemic anyway. And often the postgraduates, when they face a child or an obese child, most of the times I have seen that they are in a hurry to investigate, send a lot of investigations. But there is a logical approach to the child so that we don't run into unnecessary investigation and over investigations. And that is what I think is important here. That is where I think this series is going to help them to have a logical approach. And it is one of the very important topics in terms of exam too. I mean, every year almost there will be some questions or the other about obesity. So I think it's going to be a very useful session for the postgraduates.
Thanks, Dr. Somana. So we'll be talking a lot about with regards to the different aspects of obesity, what causes obesity, and we'll move forward to that. So without wasting any time, we'll right away start off with the session. And I'll be starting with the first case scenario. Just give me a time. So how it is important for obesity to have significant implications in terms of overall assessment and diagnosis. So we'll be starting about this aspect of obesity. And so I think, are you able to hear me now? There were some issues in terms of audio initially. Yeah.
Yes, sir.
Okay, sure. So the talk today will be focusing about different aspects of obesity as to what exactly causes obesity and how we can overall improvise in terms of overall evaluation and management. And so we had the 16-year-old boy with obesity who presented with significant obesity, and we can see the height was 165 centimeters. The BMI was significantly elevated, and the child actually had a waist circumference which was 126 centimeters, and we can see a lot of acanthosis which was already there. At that point of time, some basic evaluation was done, and that evaluation showed a TSH which was mildly elevated. Started on thyroxine, and everybody was happy that now, okay, we have got this thyroid issue and we can manage it accordingly. 1 year later, after starting thyroxine, presented with frank complications of type 2 diabetes along with non-alcoholic steatohepatitis. Now, this is a very, very common situation wherein people are diagnosed as hypothyroidism based upon just a minor elevation with regards to TSH level. The treatment is initiated, and that often is not the cause, because this is the effect of obesity and not the cause of obesity. And this is something which we'll discuss subsequently. So this was one situation where we unnecessarily created a pathology out of physiology. Now, this was a 12-year-old girl with obesity. Again, this girl was obese, but what we're noticing compared to the first boy is that she was short. Her height SDS was -2. So this is a short and plump child. All the screening tests were normal. She was advised lifestyle measures and now presented with rapid weight gain. So if we compare with the first case where we had made a pathology out of physiology, this was actually a pathological cause, which was considered as a physiological cause. And by the time the child came to us, she had frank features of Cushing syndrome, and evaluation and management confirmed the diagnosis. So the key aspect as far as the evaluation and management of obesity, as was discussed by Dr. Somana, is with regards to not doing too much workup where it is not required, but to do workup when it is very, very important in that regards. So we are seeing obesity pandemic. It's a very, very common problem. 10 to 15% of population across affluent studies will show you 98% of children who have obesity have a physiological cause. So only 2% will have a pathological cause. The key focus in this scenario is to identify individuals who have a physiological cause, who do not require evaluation, while not missing a pathological situation in that regard. So there is a careful need for assessment and management in that regards. So in this lecture series, we'll be talking a bit about physiology, what causes obesity and how obesity interacts with different hormones. Then Dr. Somana will discuss about the criteria and etiology. I'll go forward towards approach, assessment, and management, and then we'll have the Q&A with Dr. Somana about the various questions which usually may come in terms of pediatric examination in that regards. Now, all of you can go and have a look at our website, learning.growsociety.in, which has got a lot of information with regards to different aspects of pediatric endocrinology. You can have access to our e-learning modules, which are there in the YouTube, and we'll be posting these videos as well very soon with regards to these summaries. We have got a comprehensive validated program for learning in pediatric endocrinology with tools and practical assessment in that regards, including fellowship programs, which are a hybrid online on-site program over a 2-year period, and pediatric endocrinology for postgraduate, which provides a 3-year access to our common modules that we're discussing, the entirety of 40 modules which are there in that regards. We also have 3 specific aspects which are there in terms of grand round. So we do have a postgraduate grand round. We have endocrinology grand round regarding more complicated cases. And finally, this monthly postgraduate lecture series, which aims to cover the entirety of pediatric endocrinology over a 3-year period, which we're going to cover. You can also access our publications, both basic as well as advanced pediatric endocrinology, and have a look at a mobile application available on both Android and iOS stores, which provides a comprehensive information about each aspect and practical tools to identify bone age and growth interpretation. So without wasting any more time, we'll be focusing about physiology of growth hormone, obesity. And what we need to understand is that when we talk about obesity, we talk about fat. So fat is actually a stored form of energy. So whenever you're talking about fat or adiposity, we need to understand that this energy, which is stored in the form of fat, is coming mostly from the food intake. Now, this food intake could be as part of what is required for survival, could be for something like pleasure. So often we eat as far as some party or some other activities, or as part of stress. So whatever you take is in the form of the intake, and what you spend out of it is basically in the form of the resting energy expenditure, as well as which depends largely upon the lean body mass and physical activity. So the net difference between the intake and the output, the excess energy, is stored in the form of the fat. So when we talk about specifically with regards to obesity, we're talking about increased level of energy. So obesity is essentially a balance issue with regards to the energy in that regards. Now, most conditions which call obesity are largely because of increased intake. Reduced expenditure is there. It is a contributory part, but it's largely increased intake, which is causing the entire problem in that regards. So we need to really understand as to what really controls our intake. And one of the very important markers which comes out, which is basically a marker of energy status in the body, is leptin, which is adipocytokine, which is produced by the fat cells, which provides the information about how much energy in there in that regards. Now, the whole process of this appetite or eating, and I've said that eating is a major factor which regulates the overall process, requires a close interaction of pathways which cause hunger on one side, which are the orexogenic pathways, and the pathways which you are going to say, okay, now you have enough to eat, and they will cause suppression, the anorexic pathways in that regards. And the main processing unit of all this is in the hypothalamus. So mediobasal hypothalamus is the central processing area. In the ventral medial hypothalamus, the arcuate nucleus and the nucleus tractus serratorius, these are the regions which actually are the major determinants about how much we're going to eat in that regards. So they are the anorexic pathways, which are the POMC pathway, and the orexogenic. So the anorexic pathways are activated when we have enough level of energy, and they will say, okay, we do not need to eat. And the orexogenic pathway will be stimulated when the energy levels are low in that regards. Now, how does the body know that the energy levels are high? The signals start right at the time when you're eating. So when there is a distension of the abdomen, the vagus nerve will be suppressed, and that will cause more appetite. In situations where the stomach is not distended, the stomach sends a signal called ghrelin, which will then demand with regards to the intake of food. And once the food intake comes in, there will of course be distension, and the ghrelin levels will go down. The other signals which will tell us whether we have got enough energy are the level of nutrients in the body, the energy in the form of ATP, and some intestinal signals, the most important of which are the known as incretins, the GLP-1. Now, this GLP-1 is secreted once the food reaches the duodenum, and body says, okay, now we have had intake, we should shut down, and it will really activate the anorexic pathways along with neuropeptide Y and cholecystokinin. Pancreas also produces insulin, which again would be produced only when the glucose levels are high, and it will say, okay, the energy intake is less, along with amylin. And as discussed earlier, the adipocytokine leptin, which is the most important marker, so to speak, as far as the energy status is concerned, is going to then have an effect on the anorexic pathway. Now, there is also an efferent pathway, which really controls the energy expenditure. So the energy intake and expenditure are both correlated very closely in that regards, and this efferent pathway is regulating the energy expenditure. Now, what we need to understand, and this is very important from a clinical perspective of evaluation, that obesity has a huge impact on a number of hormonal systems. So obesity has a definite impact on the thyroid system. Essentially, when somebody is becoming obese would mean that there is a lot of energy in the body, a lot of fat in the body, and body will like to utilize that energy. So in the setting of obesity, leptin levels will increase, and they will try to induce a hyperthyroid state so as to allow the loss of energy. It will stimulate TRH, it will stimulate TSH, but the mechanism will fall there. Despite all these efforts, a thyrotoxic state is not produced. So in a very important perspective, obesity has an effect of increasing hypothalamic action and TSH level. And this TSH elevation is therefore the effect of obesity and not a cause of obesity. Now, as we showed in the first case, a large number of children will have subclinical hypothyroidism, TSH between 4.5 to 10. In the setting of obesity, these do not require treatment because it's not going to help in that perspective. So this high TSH, normal T4, normal T3 is the classical picture which we see in the setting of obesity. It's a compensatory response which improves with treatment. And definitely, if you correct obesity, it will improve. There is no need of thyroxine unless there is a TSH which is more than 10, or there is evidence of autoimmunity in the form of TPO positivity. So we'll see this example of a 12-year-old boy whose height was reasonable, was obese, and bone age was also normal. Now, TSH was 7.91, was advised treatment. So if you look at the oral analysis and interpretation of this child, he has a constitutional. He is a tall and obese child, doesn't require any evaluation and management in terms of thyroid perspective. So this TSH of 7.91 is actually the effect and not the cause of treatment, and we need to follow up, and in most cases it will improve over the next 2 months or so in that regards. Now, how does obesity influence growth? And this is where we need to understand, because it has huge implications as well. So in situations where the body fat is more, the body will perceive we've got more energy, and we can use this energy for very important work which are energy intense, and growth is of course energy intense work. It will cause an increased level of insulin because of insulin resistance. This insulin will reduce the insulin-like growth factor binding protein, increasing the free IGF-1 level. So obesity is associated with increased IGF-1, causing increased growth. So therefore, obesity is associated with increased growth. Every child who is obese should be tall. If you have a short child with obesity, you're dealing with an endocrine issue like growth hormone deficiency, hypothyroidism, pseudohypoparathyroidism, or Cushing syndrome in that regards. Insulin also has a direct effect in that regard. So overnutrition is resulting in a greater production of IGF-1. And theoretically, when your IGF-1 goes up, the growth hormone levels will go down, and you may have a false diagnosis of growth hormone deficiency in terms of that regard. So obesity is associated with rapid growth. Decreased growth is very, very important. So this is the fundamental paradigm when you're evaluating a child with obesity. You expect that a child who is tall, whose height age is more than the age, has a nutritional pattern of obesity, while if you have a growth chart like this, in which your height is compromised, you have a short and plump child, like the second case we discussed, is clearly an endocrine cause, which is very important from that regards. Now, besides the growth and thyroid, there are significant impact on the hypothalamic pituitary axis, and this is very, very important because in obesity, there is a peripheral production of cortisol. The activity of 11-beta-HSD, which activates cortisol, increases, and the cortisol levels goes up. So therefore, obesity is quote unquote a pseudo Cushing's disease. So often, as discussed, we will get the cortisol level assessed in children with obesity, and we'll find the level to be high. This does not mean that the child has Cushing syndrome. It's just because of obesity that the cortisol levels have gone up in that regards. Now, leptin will also go up. It will have an impact on the insulin sensitivity. So the cortisol production will go up in that regards. There will be high cortisol, as we discussed in this setting. So we had a 14-year-old girl with obesity. Blood pressure is 120/80. There is some pigmentation. Cortisol was high. ACTH was in the normal detectable range. And then somebody thought this is a ACTH-dependent Cushing syndrome, and MRI showed a pituitary adenoma. Now, do we agree with this diagnosis of a ACTH-secreting pituitary adenoma causing Cushing syndrome? No. This cortisol elevation is actually the effect of obesity. And this is basically, we should have done an overnight suppression test to get a diagnosis, and overnight suppression was really normal in that regard. So this highlights the importance of how obesity can result in a confusing hormonal picture of hypothyroidism, growth hormone deficiency, and hypercortisolism. And all three of them will ultimately have causing obesity as an adverse effect in that perspective. But what is important to understand is that on all three of these conditions, be it hypothyroidism, Cushing syndrome, or GHD, the height is less. So because your child's height is normal, it makes these possibilities very, very unusual, and don't get confused in that regard. Obesity has a significant impact of puberty in girls, and it's known that because of higher level of leptin, the kisspeptin pathway increases, and there is a greater chance of entering puberty once the body has a trigger. So the pubertal onset becomes a bit earlier in obesity. However, very importantly, because obesity causes peripheral production of estrogen, this may also cause earlier pubertal onset. It also disrupts the overall pituitary axis, resulting in a disjuncted puberty. So the classical effect of obesity on puberty in girls is that you will have earlier onset of thelarchy, but the gap between thelarchy and menarche is increased. And this is very, very relevant from that perspective. Very important factor also to remember is that often these girls may have lipomastia, and often the diagnosis of precocious puberty in obesity is a false diagnosis. It is not really it's not really a precocious puberty, but just a lipomastia. What about boys? As we have discussed that in girls, there is a disjunction between thelarchy and menarche. There is also a disjunction in boys between pubarchy and gonadarchy. So in the setting of obesity, because of increased leptin levels, there are peripheral production of estrogen goes up because of that perspective, and that suppresses LH, causing a suppression as far as a central precocity, central development is concerned. So there seems to be a delayed puberty, but because the adrenal axis is activated because of insulin, there would be a pubic hair growth which will happen. So you will have a classical example of pubarchy, which is there with small testicular size. So in a way, obesity causes significant impact of puberty in both boys and girls. In girls, it largely presents with a situation of early thelarchy with a prolonged onset of menarche. In boys, it causes pubic hair growth, which may be precocious, but puberty will be delayed in a gonadal angle. So we had this 12-year-old boy with pubertal concern. He is in the obese range. SPL is normal. The testicular volume is prepubertal. There is stage 3 pubic hair development. The investigations show everything is normal. So this is a classical example of this adrenarche-gonadarche disconnect. And whenever you have an adrenarche-gonadarche disconnect, you will automatically have gynecomastia, which will happen in this perspective. Now, we are all very, very concerned about complications of obesity. So what causes those complications is essentially the overspill of body fat. Whenever we take fatty acids or energy, we know that till a particular level, the body can store it in the subcutaneous tissue. Once the level of the fat overcomes this cutaneous storage capacity, it goes to be deposited in the visceral areas of the liver and the pancreas, inducing not only causing fatty liver and gallstones, it also causes insulin resistance, which is the primary secondary drivers in terms of obesity complications. And these would include type 2 diabetes, polycystic ovaries, hypertension, dyslipidemia, sleep apnea, intracranial hypertension, and a lot of other complications which are there. So in essence, when we talk about obesity complications, we're talking about a greater amount of fat load than the storage capacity of the body. So individuals who are small for gestational age cannot store enough amount of fat in that perspective because their capacity to store is less. So they at a lower weight level will have more metabolic complications as compared to somebody who is AGA or SGA, and that becomes very, very important. So having discussed about the overall pathophysiology, especially with regards to the causes of obesity, the impact and the interaction of obesity with hormones, the growth hormone, the cortisol, the thyroid, and the gonadotrophins, and the complications, the stage is now set for Dr. Sumana to talk about very important topics of criteria, as well as the other aspects of etiology of obesity. So I'll hand over to Dr. Sumana to carry forward from that regards.
Thank you so much, sir. Good evening, everyone. I'm very honored to be a part of this beautiful initiative for the postgraduates, and it is a wonderful learning process for us as well. Shall I start sharing the screen?
Yeah, please share the screen.
Okay. Is it visible?
Yes, yes, it's visible.
Okay. So as Sir said, obesity means excessive fat accumulation, which is detrimental to body's well-being and health. But when we talk about obesity, there are certain criteria that we have to follow to define obesity or overweight children and adolescents. So there are different markers of adiposity, but the most common and the practical one is the body mass index. So the other ones that are there are waist circumference, of course, skin fold thickness by Harpend and calipers, and of course, a very sophisticated ones like DEXA, bioimpedance, and plethysmography. But today we are here to talk about body mass index because that is what is usually followed. So while defining obesity, we have to strictly divide as per the age group. So in less than 2 years of age, we take the weight for length. And when the weight for length is more than 97.7 percentile for the WHO growth charts, we call a child as obese. For more than 2-year-olds, we take the BMI. So when the BMI is more than 90th percentile for the age and sex of the child, we call the child as obese. If it is between 85th and 95th, we call the child overweight. You can see in the following charts. One is the WHO charts for the under 2 and the CDC charts for the more than 2-year-olds. Now, the BMI and the mortality shows a J-shaped distribution, as you can see in this chart. What does that mean? And where from do we get all these cutoffs? You know, these numbers that we deal with. Aren't you curious about that? So if we go back and see, then actually there have been lots of changes and evolution of these things, of this cutoff. So what happened, there was a study where it was shown that the people who had BMI of more than 25 and above and 30, you know, there were these bumps acting here and here, which means these people had more mortality rates. So you see 25th and 30th. So these children were more prone to all sorts of complications. But the interesting thing is Indians as a race, as an ethnic group, they are very special. Why? Because it has been seen that even at lower BMI, they have more visceral fat distribution. Therefore, they're more prone to develop the cardiometabolic complications or metabolic X syndrome. Okay, so that's what for us, for Indians, the cutoffs have been come down and they have been made like 23 and 27 for overweight and obesity respectively. So for us, it is 23 and 27 respectively. Now, it all started with the CDC charts for the American population. Now, what happened was in the CDC charts, as you can see here, there are 8 percentile lines, and it applies to all the American children. And here, they said that more than 85th percentile BMI would be like overweight children, and more than 95th would be obesity. So only it so happens that only it's a kind of a flawed chart, because you see only then we will be underestimating obesity in our population at least. And severe obesity would be defined as per this chart, that is more than 120% of the 95th percentile. So for us, CDC charts are of no use, to be very honest. So then came the International Obesity Task Force charts. What they did, they took multinational data from 6 different countries, and they used the technique of backtracking, and they found out that they took the cutoffs as 30 and 25 for obesity and overweight respectively. So their levels are higher than CDC. So in a way, they were overestimating obesity again. So none of these really are helpful for us Indian population. So what happened was Dr. Khadilkar et al., they applied the same technique of backtracking and came out with our very own charts for Indian children and adolescents from 5 to 18-year-olds. They used the same technique, and then what they did was they replaced the above centiles by the 23 and 27 adult equivalents. So instead of centiles, we now take the cutoffs as 23 and 27 of the adult equivalents of the BMI. So it's very interesting, and it's really wonderful to see how these charts have evolved over time. And now it is perfectly suitable for us, for the Indian children and adolescents. But although BMI correlates beautifully to the fat percentage of the body, it has some limitations. We all know that. Now, what are the limitations of BMI? So, as I said, sometimes it doesn't differentiate between the lean mass and the fat mass. So it can overestimate with in cases of high muscular built persons. Also, in case of puberty, for example, because in case of puberty, it may not exactly correlate the obesity parameter, because if somebody is early puberty, the BMI may be higher. And in case of, as I said, ethnicity and racial distribution, as for the Indians who are more prone to have visceral fat distribution more, and at lower BMI can develop complications. So for them also BMI has this limitation. Now coming to the etiology of obesity. So beautifully, the algorithm shows that, as we all know, so there are two arms. One is the exogenous obesity or the physiological obesity, and the other is the pathological wing. When we talk about physiological, what we mean is that the crux of the cases are physiological. That is, there is no definite pathology found in those cases. 98%, as Sir said in the previous slides. Here in those obese children, it's probably due to increased dietary intake, and as we'll see later, and there is normal growth, normal puberty, and normal development. Whereas in the pathological cases of obesity, broadly there will be either genetic causes, the monogenic obesity, the syndromic children. We will also discuss about all those, with hyperphagia, maybe visual disturbances, hearing disturbances, and maybe delayed puberty, and also hypothalamic obesity cases where there will be pathological like hyperphagia, and of course the endocrine causes like hypothyroidism, growth hormone deficiency, Cushing's, and hypoparathyroidism. Coming to exogenous obesity, the commonest one, as I said, increased intake. So high calorigenic diet, eating of lots of junk food, what is very common in today's children and adolescents, reduced activity, lot of screen time, or maybe total inactivity, some genetic predisposition, etc. These are the causative factors for exogenous obesity. But we should remember, most of these children will be following a normal growth pattern, so they wouldn't be short really, and they will attain the puberty at normal age and also progress normally. And they will definitely have a normal development too. Now coming to monogenic obesity. So as I beautifully explained, the two pathways, the orexogenic and the anorexic, and the different neuro signals that tend to work on the hypothalamus, the ventromedial hypothalamus. Defects can occur at different levels, like leptin receptor, POMC pathway, and the MC4R receptor levels. And there are these, although these are very rare, but it is good to know about this causes of obesity too. We'll come to those later again. So the thing to remember here is that in cases of monogenic obesity, it is going to be early onset, so very early onset. So when we'll take a history, it's very important to know about the onset of obesity. So here in these cases of monogenic obesity, it is going to be early onset obesity. And as I said, there is going to be a hyperphagia. So like pathological desire for food. They'll be waking up at night time asking for food, creating havoc if they don't get food, and so on and so forth. And usually the obesity in these cases is severe. So the children will be morbidly obese. Now, as I said, the defect can occur at different levels. So this chart shows in a schematic style that if the deficiency is in leptin or leptin receptor, usually the common features would be an obese child with delayed puberty and maybe recurrent infections. In case of POMC defect, there will be ACTH deficiency as well here, and the children will have depigmented, because of ACTH deficiency and melanocyte deficiency too, there will be depigmented hair. And for PC1, the proconvertase 1 defect, again there will be ACTH deficiency, delayed puberty, and malabsorption syndromes. For MC4R receptor defects, which is the commonest one of the monogenic obesity, there will be signs of insulin resistance, acanthosis, and maybe tall stature. Coming to syndromic obesity, we have all seen these children in our OPDs. So Prader-Willi, the commonest one, which will present with hypotonia, obesity, and hypersomnolence and all sorts of things. And then Lawrence-Moon Bardet-Biddle syndrome with polydactyly, as you can see in the picture. And then of course Alström. Alström, again, the children come with obesity, retinitis pigmentosa, and then dilated cardiomyopathy, etc. To name a few. These children, we should remember, will have developmental delay. Characteristic features of pertaining to the particular syndrome, for example, digit abnormality, as I said, in Bardet-Biddle syndrome, and visual complaints, for example, in Alström syndrome. Coming to hypothalamic obesity, as sir explained beautifully, that usually hypothalamic obesity occurs when there is certain insult to this part of the hypothalamus in the form of either a tumor or radiation exposure, or maybe a trauma, or any kind of CNS insult, in which case there will be the children will present with hypothalamic obesity, and and these children present with a pathological hyperphagia, as I said. Okay. So coming to drug-induced obesity, again, a very important thing, we should not miss taking a drug history while we approach a case of obesity. And I am sure you all must be knowing what are the drugs causing obesity, but to name a few, and the common ones would be glucocorticoid, like prednisolone, so it can be through systemic intake, local intake, or inhaled intake, but we should try and keep it to local intake, local route only, and we should try to give it low dose and use sparing agents wherever applicable. In terms of antipsychotic medications, risperidone, olanzapine are the agents known to cause obesity. So there are drugs like ziprasidone which can be used as alternative if we want to avoid that. Antiepileptics, very common. We all know valproate, carbamazepine are known to cause obesity, and of course we know that topiramate and felbamate are the good alternatives in those cases. SSRIs, paroxetine, amitriptyline are known to cause obesity, whereas fluoxetine and sertraline can be used as alternatives. So, and coming to the endocrine causes, finally, when we see an obese and short child, as sir said, the common causes that we need to exclude would be hypothyroidism, growth hormone deficiency, pseudohypoparathyroidism, and Cushing syndrome. We should remember that in these children, the child would be obese, so short and plump. So height would be definitely affected, which is a very important thing to note. And of course, there will be issues of delayed puberty too. So coming to hypothyroidism, I'm sure you all have seen hypothyroid children. Here is a child, typical obese. The face shows, if you look at the face, it will be slightly dull looking with maybe protruding tongue. And there you can see the cuff muscle hypertrophy, which we call the Cocker-Deber-Semelane syndrome. And as sir said, these children definitely will have cognitive delay, developmental delay, and of course there will be compensatory rise of FT4 TSH almost in everybody with normal FT3 and T4. So we need not start thyroxine therapy unless the TSH is really high, more than 10, or there is evidence of autoimmunity in these children. So please be aware of that. That is a very important message for all. When it comes to pseudohypoparathyroidism, you can see the short fourth metacarpal, the brachymetacarpia sign, and there will be hypocalcemia, so Vostek sign, and of course intracranial calcification will be there, and subcutaneous calcification will also be there. These are the common pointers to diagnose pseudohypoparathyroidism. So when we do biochemical examination, the PTH and the phosphate would be high, there will be hypocalcemia, and of course these children can also present with infantile hyperphagia, etc. And last but not the least, cortisol excess, so Cushing syndrome. So we all have seen probably these children where the children have been, because steroids are used rampantly and in fact misused in all these children. So these children typically come to us with moon faces and obesity and delayed bone age, and we can do an overnight dexamethasone suppression test and come to a diagnosis. There will be other additional findings in the form of maybe hypertension and purplish stria, which will again point towards Cushing syndrome. Thank you so much.
Thank you, Dr. Sumana, for wonderfully summarizing the entire aspect of this discussion. And it makes my job much easier now to go forward on the continuation aspect of etiology and how do we approach and manage these children. So we already discussed that 98% of children who actually have these issues do have a process which is all physiological. So main aim is to identify what is pathological, and then we go forward from that perspective. So I'll just carry forward with regards to the assessment and management before we go ahead with the Q&A part in that regards. So the key questions which one has to answer while evaluating a child with obesity is it obesity or not? Which Dr. Sumana has already said that we have to look at the growth chart. Is it pathological or physiological? And of course, growth chart will tell you whether you are obese or not and use the BMI cutoffs appropriately. Three things which will tell you about pathological cause include normal growth, normal puberty, and normal development will exclude a pathological cause. So you have to work up only in those individuals who are short, who have delayed puberty and delayed development. Now, what's really the cause? So specific conditions, Dr. Sumana talked about the genetic causes, early onset with hyperphagia, vision abnormalities, and delayed puberty. Significant hyperphagia and CNS features, think of a hypothalamic cause. Delayed growth in puberty, think of an endocrine cause. And finally, what are the complications? So first issue is it pathological? So as I said, three things to look at is growth, puberty, and development. If all that is normal, you're usually dealing with a garden variety of what is known as exogenous obesity. I don't like to call it the simple obesity. Some people use that term, but that simple obesity is actually a misnomer because obesity is never simple. There will be a lot of complications which are happening from that perspective. As we've discussed earlier, if you have a child who is short and plump, think of a pathological cause. If you have a child who is tall and fat, start thinking of a exogenous cause or a constitutional cause of obesity in that regards. And this is the case, a classical case, which is very important to emphasize that if you have a mild elevation of TSH in somebody who is not short in a clinical perspective, in our terms, if the height SDS is good in that regards, do not start treatment unless and until there is TPO positivity in that regards. We have also looked into the metabolic impact of subclinical hypothyroidism, and this is our study from a clinic by Dr. Riddhi Patel, which showed that subclinical hypothyroidism was an important predictor of non-alcoholic steatohepatitis. So those individuals who have these borderline elevations do not require treatment, but you need to be aware that they have a much higher risk of having a complication in terms of steatohepatitis in that regards. So we have a 12-year-old girl, height is 130 and weight is significantly elevated, which we already discussed about the pathological cause. The initial workup was normal and now comes with rapid weight gain. And this is the classical picture of a short and a plump child. So if you have a short and plump child, always think of a pathological cause. Thyroid profile was normal and you can see features of Cushing syndrome. So very importantly, if somebody is short and plump, do not stop there. You need to do a proper evaluation. You need to do a proper management in that perspective. Now, once you know that it's pathological, the next issue is what's the cause. So you specifically ask for a detailed dietary history, diet frequency, whether they're missing breakfast, whether they're having intermittent meals, whether they are really going ahead with significant hyperphagia, food foraging, and that becomes significant. The amount of physical activity they do, the amount of screen time they spend, and we recommend 1 hour of non-academic screen time, and this includes everything in the form of tablet, mobile, laptop, and everything, along with exposure to drugs. Very importantly, ask for a detailed history of steroids. Remember that many of this may be topical, it may be inhaled. There may also be a history of non-medications like other medications like Ayurvedic or homeopathic medication, which may contain steroids. And these patients will present you with significant features of steroid toxicity, but their cortisol levels will be low. So if you have a clinical picture of cortisol excess, please do a morning cortisol, because normal recommendations are to do an overnight dexamethasone suppression test. But in these situations, you will then miss the exogenous cause. So we, as a rule, always do a morning cortisol to exclude exogenous suppression. And then if it is in the normal range or high, then we go ahead with Cushing's evaluation, because that's much, much rarer as compared to the exogenous exposure. If there is history of infantile hypotonia, following which rapid weight gain and hyperphagia, think of Prader-Willi syndrome. And if there are neurological features, think of hypothalamic obesity. Specific pointers include developmental delay, which will suggest Prader-Willi, Bardet-Biedl syndrome. If you have brachymetacarpia, think of pseudo-hypoparathyroidism. If there is features of typical facies, acromicra, almond-shaped eyes, think of Prader-Willi syndrome. Polydactyly will suggest Bardet-Biedl syndrome. Of course, if there is retinitis pigmentosa. So a history of nighttime problems, nighttime hitting to objects will give you a clue with regards to Bardet-Biedl and Alstrom syndrome. And of course, if puberty is delayed, think of syndromic causes. So rough idea is to look at growth, puberty, development, also look at the digits, the eye, the faces, the development, the vision, and these will give you a very good parameters in that regards. We have developed our obesity interpreter as part of our MedEClasses mobile application, which if you give these basic information about the height, the weight, the development, growth, and vision, we will give you the likely diagnosis, and that has been validated to be quite effective. It's going to become very soon as part of our endocrinology applications. Now, very important consideration, if you have a child who has presenting very early, start thinking of the genetic causes. So onset before 2 to 5 years of age, which is severe. If there is a family history, which is there, or a family history of consanguinity, or if there are syndromic features in the form of hyperphagia, uncontrolled appetite, developmental delay, visual abnormalities, hearing defects, and neurological features. So as for any other conditions, too soon, too severe, segregating, and syndromic. These four are the classical indications of genetic causes. And since the manifestations of these are quite overlapping, it may not be possible to go for specific genetic tests. So a lot of us tend to now go for a targeted panel, but they should be done only if these features are present, not in everybody. So the Endocrine Society guidelines really say that genetics or testing should be done in early onset obesity before 5 years of age. And those who have those genetic features which are there, you have to look for features of food seeking behavior, searching, stealing food, and that becomes important. Now, how do we go forward? You can think of doing a leptin level. If leptin levels are low, they are significant. But if the levels are high or normal, that may be part of obesity. So low leptin may be a screening test for leptin deficiency. High leptin does not make it a leptin resistant state. Very important. If you have an infant who has got rapid obesity with hyperphagia, just look at TSH and PTH. If you have a high TSH and a high PTH, this may be an indicative of a GNS1 defect in the form of resistance to both glycoprotein hormones of TSH and PTH in the setting of pseudo-hypoparathyroidism. Look at the mother. Ask the mother to form a clench the fist and see if you have a short force metacarpal, if there's obesity, if there's subcutaneous calcification, they become important. Proinsulin may be helpful in PCSK1 defect and low cortisol will suggest POMC defect. Having said that, if we have a classical feature of genetic obesity, it may be more a recommendation to do a methylation study for Prader-Willi syndrome, followed by a targeted next generation sequencing panel, which will give you the particular diagnosis. So consideration for genetic obesity is important because some of we have got treatment options which are available. Now, when do we test for the hormonal etiology? If somebody has growth failure, classical features of clinical syndrome, features of hypothyroidism, you do a FT4-TSH, Cushing syndrome, urinary free cortisol and DXA suppression. Remember, your baseline cortisol may be high because of the peripheral 11-beta HSD activity, as we discussed earlier. Growth hormone deficiency, also the growth hormone levels are falsely low. So you will have a false diagnosis of GHD. In adults, there are different cutoffs which are available. In children, we don't have a different lower cutoff for obesity, but don't do unnecessary growth hormone stimulation tests unless they are classical clinical features. And of course, calcium, TSH, phosphorus, and PTH we discussed could have a role. So if you have a child with obesity, look at three things: growth, puberty, and onset. Also look at the vision, probably will be quite helpful. If everything is normal, this is exogenous, do a complication screening. If you have a slow growth, think of endocrine parameters like thyroid, cortisol, and PTH. If it's all of them are not there, if you have an early onset, developmental delay, dysmorphism, visual abnormalities, think of a genetic cause. Think of karyotype, Prader-Willi studies if you find developmental issues. If they are not, you can go ahead with a targeted panel. Now, 98% of your patients will come here. They will have normal growth, normal puberty, and they will have onset after 5 years. Not much to be done. But because if you label them as simple obesity, you will not do any complication screening. They definitely require evaluation. Slow growth, around 1 to 2%, and these will be 1 to 2%. So this approach will really restrict the amount of workup which is required. And that's because next month we're going to come up with an obesity interpreter. If you just put those 5 findings, you will get a proper classification as to what will be the diagnosis, what will be the investigations as part of our MedEClasses app. So we'll run through quickly with regards to a few cases. 3-year-old girl with rapid weight gain, and what we can see, she is 26 kgs, very, very significant, severe hyperphagia since birth. So now we are dealing with a case which has got an early onset in that perspective. Now, what we are seeing is that basic workup was all normal, development, vision, everything was normal. There were, however, history of infections, and this could be a clue because leptin is involved in modulation of immunity. So if you have recurrent infections, it may be a leptin issue in that regards. Now, leptin levels were found to be low in that regard and found to be leptin deficiency. So if you have a very early onset hyperphagia along with growth failure, along with that abnormal growth and immune infections, think of a leptin deficiency in that regards. Now, this again is a 2-year-old girl, and we can see quite significantly obese. Now, what should we do? We need a genetic analysis or not? Definitely, this is too soon and too severe. We need to evaluate. There are no clinical features. So genetic testing was done in that regards, found to have a leptin receptor defect. 4-year-old boy with hyperphagia, again, weight is 28. And what's significant is that he is very, very tall. So you've got a tall and an obese child. The development and vision is normal. So again, if you look at our parameters, we'll go more towards the workup. The basic workup was normal and vision was also normal. There was significant acanthosis. So early onset obesity with normal development and vision and acanthosis, we did the panel defect and it found to have MC4 receptor defect. So very important to think of a targeted panel when you have specific conditions in your mind with these parameters. 7-year-old boy with rapid weight gain. Now he is short, as you can see, and tall. So short and plump becomes important. There is a history of infantile hypertonia and failure to thrive, and we know that this is an important pointer. There is now an uncontrollable or unsatiable appetite. There is developmental delay. Basic workup is normal. And if we look now that we need to go ahead with a methylation study for Prader-Willi. So Prader-Willi methylation study is very, very important in acromicra, small hands, almond-shaped eyes, prominent philtrum, infantile hypotonia. Always think of Prader-Willi syndrome. And these conditions may have a responsiveness to growth hormone in that regards. 8-year-old girl with obesity, and we can see significant obesity, short stature, again, increased appetite. There is now a history of difficulty in night. The parents say that she has a tendency of hitting objects at night. Now, I think we're getting the clue. And if we look at the feet, we are seeing that there is a polydactyly. So this is a classical presentation of Bardet-Biedl syndrome. And she was started metformin because of insulin resistance. So if you look at clues for very early onset, for growth abnormalities, for developmental abnormalities, for polydactyly, for other parameters, you will get a diagnosis in that regards again. Now, once we know what's the cause, and I would say 98% you will go towards a physiological cause, you still have to look for the complication. And that's very, very important because as discussed, obesity affects head to toe, and this involves everything. So a careful evaluation is essential, right from fatty liver to type 2 diabetes, hypertension, and polycystic ovary. One thing which often the pediatricians don't do is to measure blood pressure. Now, our studies have shown an alarmingly high rate of hypertension in community as well as clinic practice. So if you see an obese child, please measure the blood pressure. It should ideally have been done with everybody, but for obesity, it becomes very, very important in that regards. You can also have history of slip capital femoral epiphysis. So somebody who was doing fine suddenly wakes up in the morning, has a limp, leg pain, knee pain, think of it. Sleep apnea, daytime somnolence, not feeling well, worsening of school performance, think of a sleep apnea in that regards. Now, often obesity can cause a lot of other problems which are not there presenting like that. So if you have complaints of micropenis, it may actually be a buried penis. If there is features of rickets, it may actually be genovalgum, which is because of obesity, but not rickets. And often gynecomastia and precocious puberty, you will falsely label because of that. So all you have to do is to approximate with thumb and finger. If there is a resistance, it's actually breast tissue. If there is none, it is fat. So don't unnecessarily evaluate for micropenis, rickets, or gynecomastia, precocious puberty in this setting of obesity. So we had this 8-year-old boy with small phallic size. Height was all right. Testis is normal. Now, there is no polydactyly, there are no other clinical features. All you need to think of that this is a buried penis. Once we press the suprapubic fat, the penile size was normal. So micropenis is something you should not unnecessarily label in somebody with obesity in that regard. Now, what investigations to do? And I would say the fundamental investigations would be blood sugar. And we would rely on a fasting and a 2-hour value of 1.75 gram per kg to a maximum dose of 75. The cutoffs are same as far as adults are concerned. And we are seeing a number of patients with dysglycemia. HbA1c is now recommended as far as the adult criteria if we are doing it with a standardized assay. Having said that, there is a lot of issues in terms of correlation in adolescents with the glucose value. So if you're sticking for a particular diagnosis, go with fasting and 2-hour value rather than just HbA1c in that regard. Very importantly, the levels which are recommended for evaluation for cholesterol, LDL, triglycerides are different in children as far as adults are concerned. So you look at the report, don't go by the reference range, which is usually the adult range. Look at these cutoffs of more than 200 or more than 130 as very, very significant, and even 110 and above for LDL and 90 and above may have an issue in that regards. Now, HDL, again, less than 40 becomes significant. There's a lot of debate as to what should be a significant AST levels. Generally, we see a huge amount of non-alcoholic steatohepatitis. If the levels go beyond 40, we get concerned. Beyond 80 is very, very issue, because that means that there is a very limited chance of recovery from that perspective. Now, we evaluated the metabolic complications in obese children and found that it was around 40%. And beyond a particular level of obesity, the body fat, the BMI, the waist circumference did not predict. So there is a 40-50% children who will have metabolic complications. Some of them may not have at the moment. And the most important parameters which predict them are a low birth weight and a family history of diabetes. So the key modulators, so to speak, of obesity complications are birth weight, because if you're born with smaller weight, you will have lesser capacity to store fat, and a family history, which is in a way a surrogate marker as far as genetics is concerned. So we discussed earlier also the 16-year-old boy with obesity, significant amount of obesity, and had all the complications, had type 2 diabetes, steatohepatitis, dyslipidemia. What to do is a big complication, and lifestyle metformin becomes important in that regard. Now, on follow-up, this child now presents to us with weight loss, but suddenly has developed limp. There was difficulty in walking, pain in left knee and hip. X-ray showed this particular finding. So what are we seeing? This is a slipped capital femoral epiphysis. So if you have a child with obesity who complains to you with significant pain and limp, start thinking of slipped capital femoral epiphysis, which is significant in that regards, and surgical intervention may be required in this setting. Now, how do we manage obesity? The key to management is prevention. So then this prevention starts right from the infantile period. The key 3 parameters to look at is exclusive breastfeeding, which prevents the development of obesity till at least 6 months of age. Free food choice, allow the child to eat whatever they want, don't force them anything. No television or screen till 2 years. These are the AAP recommendations and very effective in that regards. In children, more issues about not adding sugar in meals, so having water as drink, low-fat milk and physical activity. And in adolescents, the key aspects are to reduce screen time, inactivity, and a healthy eat out. And these preventive strategies are very, very important in that regards. In our community study, we found that lack of sleep and physical activity were the 2 most important modifiable factor which predicted the body fat in children in the school. So if you have increased the sleep by 1 hour and physical activity by half an hour, you would have significant impact with regards to their body fat, BMI, and obesity. So these 2 are the modifiable factors which are important. Now, if we go by the guidelines from the Endocrine Society, they show that if you have a reduction even of 1 unit of BMI, you will have definite improvement in terms of blood pressure, in terms of triglyceride. There would be other improvements as well. Now, how aggressive should you be? This is an important parameter. The main message here is that children are growing. If you do too much restriction, there may be an impact as far as their growth is concerned. So the initial target is weight stabilization. If the weight is stable and the height increases, the BMI and the BMI SGS will automatically improve. The aim ultimately is 7 to 10% loss over a 6-month period. In growing children, we want a loss of around half to 1 kg a month. But even in adolescents, we don't want more than 1.5 kg per month. So 10% loss over 6 months. Somebody who is 80 kgs, you want to lose 8 kg over 6 months. 1 to 1.5 kg per month is what we are looking at. We do not want in that perspective to have significant loss, because BMI SDS will automatically improve if the growth is improving. Now, what should we do? Lifestyle is the mainstay, but the most difficult to implement. Very important to have a regular meal, regular breakfast, avoidance of snacking, increase water intake, physical activity, 45 minutes minimum, 5 days a week. No to sugary drinks, and avoidance of screen hours will become important. These would have some impact as far as BMI is concerned, but often this will have a temporary effect and it is often not sustained. This makes it difficult. So what can we do in terms of treatment? The treatment of childhood and adolescent obesity is extremely challenging. Very few drugs are approved. Orlistat is one drug which basically inhibits the absorption of fat. So it inhibits the gastric lipase. You will lose fat, but there will be steatorrhea and there will be other problems which will happen. Growth hormone will have a role, particularly in Prader-Willi syndrome. Metformin, if there is associated diabetes or steatohepatitis, or there are antipsychotic drugs. So metformin is not an anti-obesity drug. It is approved for treatment, FDA approved for treatment of children who have type 2 diabetes and obesity. GLP-1 receptor analogs, as I discussed earlier, the GLP is the incretin, which is produced by the duodenum, which causes prolongation of gastric motility. It causes suppression of appetite. The analogs are being now approved in adults, and there are few studies in adolescents also for treatment as far as the obesity is concerned, but this is not recommended at the moment. If there is hypothalamic obesity, we can consider octreotide as an option, and of course leptin deficiency, leptin, and for specific POMC pathway defects, the MC4 receptor agonist, but these are for the specific genetic conditions in that regards. So orlistat is the gastric lipase inhibitor, modest improvement, 5% reduction in BMI SDS, approved beyond 8 years of age, around 12 years of age. Metformin is an insulin sensitizer, not for everybody. If you have associated type 2 diabetes, steatohepatitis, and antipsychotic induced obesity, there will be an improvement. Octreotide for a hypothalamic cause, growth hormone for Prader-Willi syndrome, leptin specifically for leptin deficiency, and setmelanotide, which is the MC4 receptor agonist for specific conditions in which the pro-opiomelanocortin pathway is affected. And GLP-1 receptor analog not approved in children, but they are getting to be approved in adolescents soon, hopefully already approved for adults by FDA in that regard. So 13-year-old boy with rapid weight gain on risperidone, which is antipsychotic, increased appetite, normal basic workup, and we see that there is hyperglycemia happening, there is steatohepatitis happening. Metformin is one thing. So antipsychotic induced obesity, which is now becoming common, you can think of metformin as a treatment option, which is there in that regards, and that is effective in that perspective. What about bariatric surgery? Now, bariatric surgery is clearly not the treatment of choice in that setting. It is basically used only in extreme cases. The options include a laparoscopic gastric banding or a sleeve resection in which we remove the part of the stomach. So there's a rapid gastric emptying. Immediately GLP comes into the picture and that will improve. There are other options available. We talk more about restrictive procedures in children as compared to the malabsorptive procedures. They will have a problem. Usually they are to be done in pubertal stage, only after puberty, in somebody who has significant obesity with comorbidities and after a comprehensive psychosocial assessment. So it should be the last step as a life-saving procedure and not as a routine procedure. Gastric balloon is also something which is now coming up. as a parameter. So I think we've discussed a lot with regards to that. I'd like to now invite Dr. Sayan and Dr. Sumana. Before that, we'll just take a few questions in the chat. Is weight reduction appropriate for all age groups? So weight reduction is only there specifically if you are not in the initial phase. For growing children, we talk more of a weight stabilization. Reduction is very important, specifically in a later perspective as discussed in that regards. Now, statins not in the initial phase, but if your persistently LDL is more than 130, you will consider statins in that regards. Now, we'll start off with our Q&A session. Dr. Sain, over to you, and to Dr. Sumana.
Thank you so much, sir. So this segment of question and answers was specifically created for the postgraduates, because after all this working hard for 3 years, it essentially boils down to the D-Day, where you have to write well in the examinations and pass it well. And who better to tell us about the same than a postgraduate examiner herself, Dr. Sumana. So ma'am, please tell us the secrets of answering well in the examinations. Starting off with the first question of diagnostic criteria for obesity.
Thank you so much, Shayan, for collecting all these questions. I think we already had a very detailed discussion already, and these are all the revision slides, and I'll be only recapitulating the main points. So as discussed, we have to define obesity as excessive fat distribution, detrimental to health and well-being, and then we have to tell about the criteria according to age. Less than 2 years, as you can see in the slide, weight for length or height more than 97.7 percentile of the WHO broad charts, more than 2 years, according to BMI, more than 90th percentile. However, I think it would be good to mention that the Indian standards have now been modified, and we should include that the now overweight and obesity are defined as more than 23 adult equivalent and more than 27 adult equivalents.
Yeah, I think that's a very, very valid point by Dr. Sumana, that we should consider now the IAP criteria, which are the backtracking from 27 and 23 in that regards. Yeah.
Yes.
And these are the IAP criteria which we are discussing about.
Already
27 and 23
yes.
From that regard.
Yes.
The second question is, what are the causes of childhood obesity?
Again, very well discussed already, but again to recapitulate, so you can write the commonest form is the physiological or the exogenous obesity, and where it is characterized by normal growth, normal puberty, and normal development. And the other arm would be the pathological causes. And we can divide again into genetic, the monogenic obesity, syndromic obesity, hypothalamic obesity, and of course the endocrine causes. Very important, we have to mention hypothyroid, growth hormone deficiency, Cushing's, and PHP, the pseudo hypoparathyroidism. And we can also put the pointers as where we can get the pubertal delay, where we can get hyperphagia, as beautifully explained in the diagram here, the slide here.
And I think the key message would again be from the examination perspective is to say that physiological causes are by far the most important, 98%, as compared to just 2% in the other causes. That will be important.
Yes.
Yeah. The next question is of how to approach a case of obesity.
A very important and a very common question, I must say. And in any approach question, not only for obesity, we first start with a good history. So it is the history, as Sir mentioned, should start with the onset and then go about as to how it progressed and what are the dietary intake like, what is the activity level like, and I think this has already been discussed in details. Any drug history, if any, the developmental assessment. So that would be the history, then going on to the examination again. So very important actually. So from head to examination, along with the anthropometry, and vital measurements, and looking at the particular pointers to certain diagnosis. For example, polydactyly, the visual abnormalities, and the tone in terms of hypotonia, or the brachymetacopia to point at pseudo hypoparathyroidism, and the typical faces for the syndromic ones. This will, we should write the features and then write the syndrome associated with it. That would make the answer look very interesting actually. So that is the examination, and then of course going to the investigation. As per the algorithm given here. So the approach would be first to establish that the child is obese by measuring the weight and height and calculating the BMI and C on the charts, plotting on the charts to see where the child is actually. And then we should take the history and see whether it is exogenous or it is pathological when we come to a like short and plump child. And then, of course, we will work up accordingly. For example, in case of normal, the physiological obesity with exogenous causes, we just do the screening for complications and not do any unnecessary workup. For those with early onset developmental delay and children with dysmorphism, we actually do the karyotyping or the methylation study for the specific syndrome like Prader-Willi. And of course, we don't need any targeted panel for any other obesity. For those with endocrine causes like hypothyroid with specific pointers, of course, we will do the FT4 TSH, cortisol, and of course, parathyroid hormone, as beautifully explained in the slide and earlier also explained by Sir.
Roxamana said it very nicely, and it's always better to have a more point-wise approach. So point-wise write-up as well as tables will really help in terms of, as she said, features and the likely diagnosis that we make, that you know it very, very clearly in that regards.
Ma'am, this has also been discussed. What are the comorbidities generally associated with obesity?
Okay, so comorbidities or complications, they will be synonymous. And again, as discussed by Sir, we should write, as per the, the commoner ones should be written first and then the less common ones later. So of course, as we know that the fatty, as Sir beautifully said, that the non-alcoholic steatohepatitis, then insulin resistance, type 2 diabetes, hypertension, dyslipidemia, sleep apnea, polycystic ovaries, these are very common. And then coming to the orthopedic problems like SCFE, slipped capital femoral epiphysis, or maybe osteoarthritis, and then glomerulosclerosis, and all these things. So start with the more common ones and then write the less common ones later. Yes.
The next question, ma'am, how to work up a case of an obese child.
Okay, so laboratory workup is written here. So as Sir said, so laboratory workup in case of exogenous obesity, it would be pointing to do the screening for the complications. And so we would do like the fasting blood sugar, HbA1c, lipid profile, and then SGPT, in the liver function test. We can do an ultrasound to look at the liver. And of course, for genetic obesity, if it is like pathological, then again, depending on the scenario, we will do genetic testing, we would do methylation study for Prader-Willi, we would do karyotyping, we would do the NGS panel to find out the specific diagnosis and all these things, I think.
Yeah.
And
so
of course, yes, so again, it's a very important slide. Yeah, as Sir mentioned. So, so testing for endocrine etiology, again, very important. So according to the specific diseases, if we think about hypothyroidism, we should do the FT4 TSH growth hormone deficiency by doing growth hormone stimulation test, urinary free cortisol, DEXA suppression for Cushing's, and then for PHP would do calcium, phosphorus, ALK-phos, PTH, and high TSH is often the first indicator of PHP, so that should be done. So TSH will be high in PHP. That is very interesting. Yes.
I think this is already what Sumana has mentioned.
Yes, yes, the cutoffs are here and already mentioned in the previous slides. So, yes. Yeah. Approach, so we already discussed, I think.
This is already.
Yes, yes.
The next very important question is how to prevent obesity from happening, the primary prevention of obesity.
Yes, very important question, actually. So, basically primary prevention will be like prenatal and postnatal. So the maternal nutrition has this epigenetic effect on the fetus, so it starts even before the child is born. So the maternal overnutrition, undernutrition, gestational diabetes have a very important role to play in for the child, whether the child will develop obesity or not. So that is very important. And then coming to postnatal nutrition, I mean, as pediatrician, we cannot overemphasize the importance of exclusive breastfeeding for the first 6 months. We all know that is so important to prevent obesity in the later life. And of course, a good diet, and then no screen time below 2 years of age, and no extra sugars or sugary drink, a proper balanced diet, low-fat milk, enough of physical activity, of course, reduction of screen time, and I think, of course, a healthy eat out. And the parents should act as role models. And we can do awareness programs at schools, and of course, the government can also take up all these prevention strategies and programs. All these can be written. You can write pages after pages for this answer and get good marks, actually.
The final question, I think, it is how to manage a case of obesity.
Well, again, beautifully explained in details by Sir. So main thing is the lifestyle modifications. So regular meals, no junk food, no snacking, and 45 minutes of daily activity for at least 5 days a week. And for more than 2-year-olds, screen time should be strictly restricted to less than 1 hour, non-academic screen time. And of course, no sugary drinks and all that. Yoga and exercise. And when all these fail, so when the lifestyle modifications fail, then we can think of anti-obesity drugs only in very limited situations also, and mostly they're experimental. The only 2 drugs that are often used are, as Sir said, Orlistat, the gastric lipase inhibitor to control the decrease of fat absorption, again approved over 12 years of age. And of course, metformin can be used not as an anti-obesity drug, but in cases where it is associated with type 2 diabetes mellitus and for steatohepatitis, and also in obesity secondary to antipsychotic medication. As Sir said, octreotide again can be used for hypothalamic obesity. Growth hormone is has been seen to decrease the fat mass in case of Prader-Willi syndrome, and that's an interesting one. And again, but the rest of the GLP-1 receptor agonists and all are again not approved for children yet above 18 years. And for leptin deficiency, we can use the recombinant leptin, and for experimental drug setmelanotide for MC4R proconvertase deficiency. Actually, that's a MC4R agonist that can be used. So this chart summarizes it all beautifully.
So I'll thank Dr. Sumana and Dr. Sayan for this wonderful interaction. You all can go and have a look at our website through these parameters, look at mobile application in which obesity interpreter is going to come very soon, our books. And we'll finally just take a few questions before we sign out from this session. There are a couple of questions in Q&A. Dr. Sabina is asking, morbid obesity in a child with normal growth requires assessment, say 15-year-old with 104 kgs, 165 centimeters. Dr. Sabina, this is clearly a case of exogenous obesity. So I would say not much evaluation. Our studies show that we should definitely do a FT4 TSH, and then mainly it will be the complication screening will be important. In that regards. Dr. Sumana, what's your thought about that?
Absolutely, sir. This is a case of exogenous obesity, and so yes, only screening for the complications.
Yeah. And Dr. Rajib is asking, can growth hormone given in Prader-Willi with OSA? Dr. Sumana?
Growth hormone, yes, it can be given, but with strict monitoring, because it can worsen the, sometimes if it is an strict monitoring of that, because sleep apnea can be worsened by growth hormone therapy.
We recommend that routine baseline sleep study should be done, and if there is sleep apnea, you should be giving with caution. Start with a lower dose, and of course consider a tonsilloid adenectomy before you go ahead with that procedure. Dr. Rajib. Dr. Rajib is also asking about administering Orlistat. Do we need to supplement with fat soluble vitamins along with drugs? So what do you think, Dr. Sumana?
Doctor, sorry, sir, I didn't. Oh, fat soluble vitamin.
Yeah.
Along
so
with
it is required because you are losing
fat
in the stool. So of course you should give it in the recommended dose.
Okay. All right.
This is a very interesting question from Dr. Anand Ramakrishnan. If a child is obese and short, but height is consistent with mid-parental height, do we need to evaluate or as long as height is within target height range, can we consider it lifestyle related even if he is short? Dr. Sumana.
If a child is obese and short, but height is consistent with the mid-parental height, yeah. No, it's a well. If it is a family, so if it is following the familial range and obese.
So if you're considering somebody to be obese and short within the familial range, you should not usually evaluate. But remember, but some of them may actually have a genetic disease. Suppose you have pseudo-hypoparathyroidism in the parents, and the parent will also be short and the genetic potential will be low, but that's because of the disease. So if somebody is very, very short, we should evaluate in that perspective. Dr. Rajesh is asking NASH, if very high SGPT, do we still give metformin? Any cutoff? So if the SGPT is 3 times above the upper limit, 120 and above, we generally avoid metformin in that setting, Dr. Rajesh, in that regards. There are a couple ones on chat as well. Dr. Sabina is asking morbid obesity in a child with normal, this we've discussed already. Should a dietitian be involved? Children not really able to follow. We should definitely have inputs from the dietitian because the counseling will help, the family will understand better. So definitely in these cases, they will be of benefit in that regards. I think there's one final question. For age less than 2 years, obesity is defined as weight fallen more than 97th centile. May I know the reference? Dr. Kiran is asking, Dr. Sumana. So this is from the WHO parameters.
Yes, guidelines.
From the WHO guidelines. So you can easily get it from the WHO parameters in that. So I think this was a very, very interesting and intriguing session. A lot of questions were generated and a lot of interaction happened in that regard. I'd like to thank all of you for joining us in this weekend. We shifted the time a bit this time because of some issues, and that's why people are now joining. So I think this could be, but all these sessions will be available on a recorded basis on YouTube. So you can all have a look at our website and YouTube channel. Once again, thanks, Dr. Sumana, for really joining us and giving this wonderful talk and interaction. Thank Dr. Sayan for doing the hard work of collecting all the questions and bringing it forward. And thanks all of you for joining us. Have a great weekend and good night, I would say, from our perspective.
Sir, I too got to learn a lot from the session. Thank you so much.
Thank you, Dr. Sumana. Thanks, Sayan. And bye for now. Yeah.